Thanks so much, Leah. We're now moving on to Unit 3, which is MAT and buprenorphine basics. In this module, we're going to talk a little bit about the science behind buprenorphine as well as the pharmacology. I'm going to talk a little bit about how the medication is dosed, and then we're going to talk about the X-waiver rules versus the 3-day rule that we implement in the emergency department. So first, what does MAT stand for? I've heard this both for medications for addiction treatment as well as medication-assisted treatment. The important thing to note is there are different types of medications that fall into this category. So we have methadone that is a full agonist, and as you can see there, binds nicely to the mu-opioid receptor. It fully activates that receptor as the dose is increased. Buprenorphine is actually a partial agonist. So as you see there, it binds a little differently, not completely, and really only sort of minimally activates the receptors. You also have opioid antagonists, which is naloxone or naltrexone, and that prevents other opioids from actually attaching to the receptor. So you can see there it does not bind at all, but prevents the binding of other opioids to those receptors. So buprenorphine, you've probably heard of, oftentimes referred to either Subutex as Subutex or Suboxone. Subutex is the monotherapy form, so buprenorphine only, whereas Suboxone has both buprenorphine and naloxone in it in a 4-to-1 ratio. It's often referred to as combination therapy, and that is available both in film and tablet form. So the important properties of buprenorphine that you need to know is that it's a partial agonist, as I already mentioned, so it only activates that receptor minimally. I think of it often as a dimmer switch for a light, for example, that it just activates it enough so that you can see what you're doing, say, in a room, but doesn't fully activate it so that it's very bright. It has a very high affinity for the receptor, so when buprenorphine is on board, it binds very strongly to that mu-opioid receptor, and nothing actually binds stronger. So if you put anything else on board, with the exception of naloxone, any other opioid does not push the buprenorphine off. It also has a very slow dissociation, which is nice in the sense that when patients have buprenorphine on board, they feel stable for a long period of time, and it slowly comes off the receptor over time, oftentimes 36, 72 hours. So patients don't have a lot of sort of ups and downs or highs and lows associated with buprenorphine. Some additional properties. So the partial agonist does have a ceiling effect, as you can see there. It's the green line, and we do see that ceiling effect at about 16 to 24 milligrams. So when you add on additional buprenorphine beyond that dose, there isn't any additive effect. It is one of the other reasons why it's often safer from an overdose perspective, or if a child gets into the medication, that your body can only sort of take in so much buprenorphine, and after that point, no more will bind to your receptors. Methadone, in contrast, is a full agonist, so as more methadone is put on board, it continues to attach to those receptors and activate them, so it is often associated with more side effects potentially as the dose increases. Several different formulations, as I mentioned. You see the buprenorphine film up in the left corner, which is the brand name Suboxone. That is actually also available generically in a film now. Subutex is the monotherapy version, more typically used just in pregnancy. It does have a higher street value and is more divertible because it does not have the naloxone on board. The naloxone is attached to the medication to prevent misuse. So if you use the medication properly, dissolving it under your tongue, the naloxone really is not activated at all. If it is misused, either snorted or injected, the naloxone in the medication is activated. So it has that's put in for basically protection and as a safety mechanism. There is also combination therapy, buprenorphine naloxone tablets that are available, and all are dissolved sublingually when they're used appropriately. Some additional buprenorphine effects. So when patients have buprenorphine on board, they generally report that they feel normal, that they can go about living their life as they wish. So they have fewer cravings for the drugs. Other drugs or any type of opioids. It prevents the opiate withdrawal syndrome as well. So again, patients can feel normal going about their day-to-day life. It does have less euphoria because of the partial agonist properties. It also blocks the euphoric effect of other opioids. So that's a common question. So if a patient has buprenorphine on board and is using, say, for example, prescribed pain medications after surgery, you do get some added benefit from a pain perspective from those medications, but it does block any euphoric effect. So patients do sometimes worry that they might feel high, and that does not happen when the buprenorphine is on board. It is also less likely to cause respiratory depression and overdose than other opiates, again, because of the partial agonist properties. It is administered sublingually, as shown in this picture. That's really important, and we want to hit on that point a number of times, in part because it's a new medication and it looks like a tablet, or new medication to many folks, and it looks like a tablet. So I do sometimes see folks walking around, say, in the emergency department with a buprenorphine tablet and a glass of water, and I always want to make sure that the person administering it knows that it is dissolved sublingually. As I mentioned, the naloxone is included to prevent misuse, but there's not any significant absorption of naloxone when it's used sublingually. Generally, patients feel stable on 8 to 16 milligrams a day. I rarely have to go above that. Sometimes patients don't require 8. They can get by on a much lower dose. It really depends, but I think people newly coming into treatment, particularly those that have been using illicit heroin or fentanyl, generally need a dose that's 8 to 16 milligrams to feel stable in the beginning. During the initial induction stabilization phase, I generally sort of will give patients 2 to 4 milligrams every hour or so until stability is achieved. So it can be dosed in that way. You generally see the effects, fairly quickly within 30 minutes to an hour. These are the formulations that are available for substance use treatment. There is also an extended release subcutaneous injection that goes by the name Subutex, which is fairly new. It is also a treatment for opioid use disorder, and it is administered once a month, injected usually into the abdomen, and just dissolves slowly over time. The other buprenorphine formulations that are available are generally used for pain. So that comes in a patch, also comes in a film that can be used called Belbuca, but different. So these are the formulations that are used for substance use treatment. The most common side effect of buprenorphine is actually headache, and I see that fairly frequently. Patients often attribute that to naloxone, but it is actually the highest or most frequent side effect that we see from buprenorphine itself. Buprenorphine does precipitate acute withdrawal if given too early, so that's really important. You need to understand whether your patient's in withdrawal before starting the medication. If they come in and they last used heroin, say 2 hours ago, that would be too early, and you'd actually precipitate withdrawal. Because as I mentioned, nothing binds stronger. So if a patient has heroin on board and then you administer buprenorphine, you'll actually precipitate withdrawal because it will push the heroin off those receptors. We do sometimes see tongue, gum, mouth irritation from dissolving it sublingually. Generally, we're able to sort of work around that in terms of sort of moving the film around, maybe just to the left or the right. Some people actually also dissolve it in their cheeks, but we can generally work around that. And you can go to the injectable if you needed to, if that continues to be an issue. So these are some of the other side effects that are reported. I don't tend to see it very much. It doesn't have much drowsiness or dizziness associated with it that I see. Generally, people feel like it provides them a little bit of energy when they take it. It certainly does cause vomiting sometimes and constipation. Usually the vomiting piece is if it's administered too early, but it does cause constipation for folks just like any other opioid. Again, sometimes people, if they take it late in the day, it actually sort of activates them a little bit too much, and they will complain of insomnia. But again, you can generally address those issues by changing how the patient doses throughout the course of the day. We try to really do either single daily dosing or at most twice a day to get around folks feeling like they need a medication to feel better. So just taking it once a day in the morning is generally what I recommend. So here's an opiate withdrawal timeline, and as I mentioned, you want to make sure your patient has an adequate withdrawal, and that really depends on the type of substance they used previously. So some of the fentanyls that are on the street right now, rapidly metabolizes, and it might be 6 to 12 hours before the symptoms begin, and sometimes they're 12 to 20 hours later, they may be in fairly significant withdrawal. With a longer acting opioid, say an extended release oxycodone or even methadone, that withdrawal picture tends to start later. But certainly within a couple days, patients will report feeling pretty severe withdrawal, and these are some of the symptoms that you would often see. They feel really, really sick when they're in acute withdrawal and seeking to avoid that feeling, which is one of the ways that buprenorphine certainly helps them, gets them out of this horrible withdrawal picture and reduces the cravings. So this is just want to consider what the patient used before you do the induction and ensure that they're adequately in opiate withdrawal before starting. If you precipitate withdrawal by administering buprenorphine, it's not the end of the world. You can't undo what you did. Just keep going. And patients again will stabilize over time. But it's best if you if you make them feel better when you give them the medication. That certainly is ideal. So this is an example of a clinical opiate withdrawal scale. So this is something that you might use in the emergency department to determine whether your patient is in adequate withdrawal to start. You add up the score. Generally, 8 or more is fairly significant withdrawal. Patient symptoms varies. Sometimes, pupils are markedly dilated. Other times they're not. Restlessness and anxiety, is somewhat self-report, but they do vary, but generally you'll see this picture. And patients usually can report what's their worst symptom or, what one comes on most or earliest in their withdrawal process. So one of the most common questions when we talk about doing buprenorphine inductions in the emergency department is whether all ED providers need an X-waiver. And the answer to that is no. And that causes a lot of confusion. But there is legislation which is linked here around allowing basically a 72-hour rule that allows emergency departments and actually other inpatient units to administer buprenorphine daily for up to 72 hours. So the key there really is administer. So the patient cannot be prescribed any buprenorphine. That can only happen if you have an X-waiver, and they can't be dispensed any. So they can't, take any medication with them. So they can be given dosing in the hospital. And then they can actually return for subsequent visits, which actually don't require a provider per se. They can see a nurse for an administration in most cases, although every hospital is different in terms of how they set this program up. But 3 days, you can administer the medication. And then so at that point, you do have to make sure that you have a warm handoff plan to an outpatient program that can provide care. But this is very much legal, provided you don't dispense the medication for them to take with them or that you don't prescribe it. Those two things do require an X-waiver. So moving on, we're going to talk a little bit about opiate use disorders and special populations. I'm going to go pretty fast through this one, but I think what the message I want folks to hear is that they really need a plan in place to address special populations that might present in the emergency department for an ED induction onto buprenorphine, because they will present, and I think it's best to sort of have a plan in place of what you're going to do so that you're not sort of scrambling at the last minute. So these are some of the populations that I talk about. Pregnant women, probably potentially the most important group, adolescents, geriatrics, homeless populations, and then the recently incarcerated. So this is a nice slide that just provides an overview of the prevalence of opiate addiction amongst pregnant women. As you can see, Maine, Vermont, and West Virginia have the highest rates. We're at about 8% of all infants that are born in the state are substance exposed. So this is a common issue, and moms will be seeking treatment. Oftentimes when they first learn that they're pregnant, they will try to get off whatever they're using because they obviously don't want to harm their baby. That's typically not successful, and there's this period of really struggling. They don't really want to be in full-blown opiate withdrawal. They don't feel well when they're experiencing that, but they don't want to use illicit substances. So this is a population that will present to the emergency department, and I strongly encourage you to treat them with MAT. The risks are so much lower, even if you precipitate withdrawal in the mom, to the risk of her going back out and having to get something off the street. So I really encourage you to have a plan. I think it's important to think about understanding how pregnant she is. If she's certainly less than 12 weeks, it's pretty straightforward ED induction. Certainly if she presents at 30 weeks, that's somebody who probably needs to be admitted for an inpatient stabilization. So you just need to decide within your healthcare system what you're comfortable with, but really important because these moms need treatment. They're desperate really to get treatment, and I think will present to the emergency department for help. So here's a quick slide with the percentage of drug-affected babies in the state. As you can see, it's about 8%, so a common problem. This is the ACOG committee opinion on opiate use disorder during pregnancy. It's a really nice link there that you can download. It's like a 5-page document, easy to read, provides a really nice overview. It's really important to ask pregnant women that you might see in the emergency department about substance use issues. There's a nice instrument in that ACOG link that I just provided called the 4 Ps. That's a really nice question, but sort of questionnaire that asks open-ended questions about, whether you've had a past history of substance use, whether your partner has issues. It's nice because it really can start a dialogue, and I think this is often difficult for people to feel comfortable asking. Buprenorphine is a first-line treatment of pregnant women with substance use disorders. For a long time, it was second line behind methadone, but it is now endorsed as a first-line treatment by the World Health Organization, among others. So it is definitely very much safe to be doing this. And if you have only Suboxone in your formulary, it's fine to give that to the pregnant woman. There's a lot of confusion around that, but if she's dissolving it sublingually, she's absorbing very little naloxone, and it won't precipitate any kind of withdrawal. And you're watching her take it because, again, it has to be administered. So it's perfectly safe to use the Suboxone. It's actually perfectly safe to use Suboxone throughout the course of the pregnancy, but don't let that deter you from starting them. Whole host of other things that need to be talked about, with a pregnant patient over time, but that can be done at the outpatient setting. It is just important to know that, withdrawal is not recommended, that we do see complications for the fetus if she tries to sort of detox herself. So really important to start MAT and have a clear transitional plan of care. Generally, a lot of other issues present with pregnant women with substance use disorders, a lot of behavioral health needs. Polysubstance use is also common, so just to be aware of that. A lot of concerns about breastfeeding and delivery, and those are all things that the outpatient program can address, but we just want to make sure that you're aware of them. One thing I do want to note is that pregnancy is actually somewhat protective from a drug overdose risk perspective. In contrast, postpartum is a fairly risky time. We see an increased risk of overdose death within the population that I care for, and that is, I think, caused by many things. Certainly, we see postpartum depression more commonly amongst women with substance use disorders. We also tend to see fragmented care, particularly where mom might go to one setting during pregnancy and then is supposed to transition to a different one, and that doesn't happen cleanly or smoothly. Certainly also women who have lost custody of their infants are often super high risk because they're very depressed, and oftentimes they might be disconnected from services at that point, particularly, say, for example, if they lose their main care when they lose custody of their infant. It's often very difficult to keep these women in treatment, and they're super high risk for an overdose death. You should be giving pregnant women that you do inductions on naloxone as well, or Narcan for them to take home, as should everyone who gets an ED induction have a Narcan kit to go with them, just to have in case it's needed. Adolescents is another population you may very well see. There's an increased risk for fatal drug overdoses within the adolescent population. The American Academy of Pediatrics is very clear that universal screening is recommended. There are some nice screening instruments here if folks want to use them. I just wanted to, again, make sure people have a plan in place. If you have a 16-year-old who shows up in opiate withdrawal and needs treatment, maybe coordinate with your outpatient program and also potentially coordinate with your local pediatric providers. But this is a population that tends not to be started on MAT. I think there's just concerns and fears about it. But it is a population that needs it if they're appropriate. And the American Academy of Pediatrics certainly recommends that. And they recommend that pediatricians become X-waivered, and certainly that we need to study this population more, but they are at risk just like everyone else of overdose deaths. And in fact, the younger individuals, females, Black and Hispanic youth, were actually less likely to receive MAT, so may be particularly at risk. Geriatrics are a little tougher, and I think the message I want folks to hear here is that, older folks do have substance use disorders, even opiate use disorders, and I think that's still not necessarily well accepted socially. So as you see older adults present to the emergency department with what I think is, a fall or some other type of issue that you might be sort of contributing to their older age, they may have a substance use disorder that underlies that. So really important to ask about it. I have plenty of patients who are over the age of 65 in my practice, so it is an issue that is present for these folks. And in fact, I think some folks who got started, when it was sort of pain was the fifth vital sign on chronic narcotics, probably inappropriately, ended up developing problems with them. And so that tends to be the geriatric population that I see in my own clinical practice. Homeless population, you're probably not going to address all the social issues that are present, but I just want people to, again, be aware that substance use disorder is a risk factor for homelessness, and that drug overdose is the leading cause of death among homeless individuals. It accounted for 1/3 of the deaths in a large study in Boston in people under the age of 45. So more common than homicide, suicide, some of the other things that we see in homeless populations. So really important to be aware that this is an issue for those that you might see that are homeless. Community responses have been really effective in a lot of places with MAT providers working with law enforcement, other services that go out into the community to help provide care to this population. They're certainly at risk for soft tissue infection, infectious disease, co-occurring mental health diagnoses. Access to naloxone is absolutely critical. So again, everybody who does an induction should get some. But this is particularly true for homeless populations. Many places are actually pursuing drop boxes. So high-risk locations where there's been multiple overdoses, having Narcan actually available there in that setting, which I fully support. Medication safety and storage is a huge challenge when you care for these patients from the outpatient prescriber's perspective, because they don't have a safe place to store them. They don't have a lockbox in their home because they don't have a home. But for the perspective of the emergency department doing inductions, it's probably less of an issue, again, because you're just administering the medication. And finally, recently incarcerated. This is a complicated group, and we've been talking about it as part of this RISE program. This group is really high risk for overdose death, which is why a lot of the jails are moving toward providing MAT in the jail setting. These are people who are not necessarily physically dependent when they come out of jail, but that first time that they are to misuse, they have a very, very high risk of death because they're opioid naive. And oftentimes the drugs that are on the street are much stronger when they've come out. So it's a group that, particularly if you have someone who has relapsed, who just got out of jail, this is a group that definitely should be started on MAT. We want to actually start them on MAT before they relapse, because the relapse is often fatal. But they will present to the emergency department, and I think really important there to have a plan as well. And access to MAT while incarcerated reduces the overdose risk death after release by 70%, so really important.